So actually, I had a question for Sutie that I didn't get a chance to ask. And it's often a question that I ask my own patients. If somebody could take away all your tics and OCD and anxiety away, is that something that you would wish that you would actually like, or would you feel a sense of loss?
I love that question. Both, of course. It would be. I have to like think. I think about it. I'd be like, ooh, no. I think I'll keep it. Because, like I said, it's almost like there's a positive component to it, which was what I'm trying to sort of demonstrate for you all tonight. There's a positive creative component to it, which hopefully you can maybe orate better than I can.
A lot of patients do actually identify, it's actually part of their identity because oftentimes it comes up in childhood and they've lived with it for so long. And
right.
A lot of patients do, a lot of people who have Tourette's actually do express that it's a certain part of them that they do like. Sometimes they like the OCD part if it actually makes them focused on certain things.
Right.
But some people do start to celebrate that individuality, that uniqueness that it gives them. So.
Exactly. Yes. Good question. Thanks for asking.
And wonderful performance. It's actually a great segue into what I'm going to be talking about today, because it gave sort of a nice background in the history of Tourette's and Gila Tourette as well. This is him, actually, and he was a student and a resident at the Hospital des Salpêtriers. There he is in the back row, second from the left, and the picture that's on your program today, and I got to what you actually recreated here tonight. There is Charcot back here, and Gila Tourette is right there. So this is actually not unlike how we conduct our grand rounds actually to this day in many different neurological institutions. Often we do have a patient coming with a certain neurological condition, and we do have them come in, we perform the neurological examination, oftentimes, especially in neurology, where the neurological examination with localization and the phenomenology of movement disorders particularly is very helpful to actually see the patient and examine them in front of you. So, and this picture was actually forwarded to me by Dorothy, and I really loved it quite a bit because it did in the caption mention that there were other people there, non-medical people, in the creative field. So this is not an uncommon pairing that we often find with neurology and the arts together. And I often wonder actually if that's not one of the reasons that a lot of neurologists are drawn to neurology, because there is that creative process. There is where creativity comes from, where identity comes from, is from the brain. And a lot of us are drawn because of that mystery, not just because of the medical science and the interest in the research behind it, but also because it's really the organ that makes us who we are. So in general, talking about Tourette Syndrome, it is a very complex neurobehavioral condition. It does begin in childhood, and it involves tics, but also, as someone had mentioned, a lot of other behavioral conditions, mainly ADHD and OCD. There's about probably 60 to 70% of Tourette's patients that actually have these behavioral conditions as well. So when we talk of, as a movement disorder specialist within neurology, we do divide movement disorders into two main categories. The first being that dealing with hypokinesia, so a lack or a paucity of movement, the prototype being Parkinson's disease. We see a lot of resting tremor, rigidity, slowness, postural instability, and there are other atypical Parkinsonian syndromes that fall within that category too. On the other side of things, we actually have hyperkinetic movement disorders that include chorea, dystonia, tics, under which Tourette's falls, and myoclonus. So they're a little bit more varied in the hyperkinetic movement disorder arena. So Tourette's actually is part of the spectrum. You can go from very mild tics, very transient tic disorder in childhood that can often disappear, kids can outgrow it, to a more chronic condition, which you have a certain particular tic, motor tic, whether it's simple or very complex, which can involve different body parts, including phonic tics as well, tics of the vocal system, to the far end of the spectrum, which is sometimes called malignant tic disorder, which is probably in about 5% of patients. And that can involve quite violent tics that sometimes can be self-injurious to the patient and would actually call for more aggressive treatment. The etiology of this does remain unknown, but it is felt to be inherited and genetic in nature. There hasn't been a particular pattern found yet, whether it's autosomal dominant, recessive, varied penetrance. That hasn't been discovered quite yet, but it does seem to run in families, whether it's, you can have a family who has a patient coming in with tics, but maybe the mother has OCD and one of the brothers has ADHD. And they don't necessarily have the same thing, but they often go together. So, as I said before, they often overlap with tics, OCD, and ADHD. And they don't always come in the equal proportions. Sometimes you can have more of the tics, which can be quite bothersome. And of course, as you're growing up as an adolescent, you can be quite self-conscious of them. But oftentimes, the behavioral conditions can be more of a problem, and actually that calls for more of the focus on the management and treatment than the actual tics themselves. If the tics actually aren't harmful to a person, generally you don't have to treat them. So it doesn't call for medications necessarily. There are certain features, which actually Sutie has already talked about, that can be associated with the tics. Often there is that urge or sensation to perform the tics. And part of my examination when I see a patient who has a tic disorder is to ask them to see if they can sit quietly for approximately 30 seconds and see if they can actually suppress their tics. And depending upon how severe their tic disorder is, some can have some success doing it, but there's a certain point at which that sensation builds up, and patients have described to me that it's either a sensation of either anxiety, deep in the pit of the stomach, or just a creepy crawly feeling just inside their body that eventually builds up, and they have to let them out. I did have a woman who I was following when I was training, who was an ICU nurse actually in New York. And she had, I would probably call moderate to severe tic disorder. And she had a certain particular neck tic that would always come out. And being a nurse and being around patients, she kind of wanted to suppress them quite a bit. And also around her own colleagues, just not to frighten anybody or, But what she would do is she would actually suppress them quite a lot. And she would go around doing her rounds, taking care of her patients. Then about 3 or 4 o'clock in the afternoon, she would have to go find a supply closet or something, go in, lock herself in, and just let them all out. And then she would feel better, and then she could go out and do the rest of her shift. So that's not an uncommon story with that. And the behavioral component can actually be quite intertwined with the tic disorder as well, if you have them together. And you were talking about some of the obsessions and compulsions that you have with it. Oftentimes, if you do have a particular tic, that can become incorporated into normal movements, whether it's shifting your glasses up and down or playing with your earring or doing something like that. It can become part of your normal incorporation. One, partly to hide it maybe in public.
Yeah, exactly.
But another part of it is some people have the urge to do it a certain number of times, and that's where the compulsion becomes intertwined with it. So I have some people that say that they need to snap their fingers or something. It's like, always has to be an odd number. It always has to be 3. Or they have to do certain things in even numbers, and they can only do it that way. Or they have to, line things up in a certain way. So that can become somewhat disturbing to some of their normal routine functioning of daily life. But in speaking with the patient, and when you build a rapport with them, you can kind of find out what they actually find helpful to them, what they find not helpful to them, and debilitating and hindering some of the things that they want to do, and that helps guide your management actually. So you've seen a lot of good examples of tics from the performance today, and these are actually some examples that I have to show you from some clinic patients. See if I can. If it works. In person. There it is. So they can involve, that'll disappear. They can involve any part of the body, really. Facial tics and head and neck tics are actually very common, and probably the most common. Blinking, eye blinking, squinting is actually very common. It can be to a point where people just really don't notice that, and they think that you just have something in your eye, and it often goes unnoticed. Another common one can actually be what you can see here is what we call oculogyric movements of the eyes, where you can see the rotation of the eyes, and that's a very common one we can actually see. Eyebrow knitting is a very common one. So oftentimes it can be involved with facial tics as well, whether it's pursing of the lips or some patients have to, rub their tongue against their teeth. They can have some scrunching of their face as well. Scrunching of the nose is actually also very common too. And again, incorporating some things into either functional movements, that itself can sometimes eventually evolve into a tic. They often wax and wane, and oftentimes one can be replaced by another. Here we have a little girl that actually does have a lot of neck tics as well. And sometimes, sometimes they can actually come to the point where they actually obscure your vision to the point where you can't see in class, you can't keep your eyes open, and depending upon how debilitating that is, then treatment and management can come about. Yes, so cervical tics can be these are a little more severe actually, and these are the tics that you start being a little bit more aggressive with treatment, because sometimes these can actually cause some cervical problems, whether it's disc rupture or even spinal cord compression, which is a serious neurological issue. A lot of these, there have been actually case reports where people have actually had myelopathies because of very severe cervical tics. So these types of things, you really do need to consider medications and other treatments for it. That's a particularly violent one. He also has some other movements that involve his arms as well as his facial grimacing. So there's a whole. This is sort of getting towards what I was talking about at the beginning of malignant tics. Some patients actually, with their obsessions, need to, if they are near like a sharp object or a corner, they have to hit their hand against it, and they can actually cause lacerations on their hands. So there can also be slower types of tics, which sometimes resemble dystonia, which is an involuntary contraction of certain muscles. You can involve these are limb tics, so a lot of things similar to Sutie, where they actually have, they can actually do some arm flexion or facial touching. You also see it at the lower extremities, where we can see some adduction tics, but also some trunkal tics as well. So sometimes it can cause some flexion of the trunk, which obviously can be quite disturbing when somebody's trying to ambulate. They can be quite complex. They don't just have to be one quick jerk. They can actually involve several different complex features as well. And we don't really have sound here, but eventually he's going to be interviewed a little bit and describing what he's feeling. He does describe certain urges to actually do them, and there are certain things that he can't suppress. So, the part of the pathophysiology of a lot of movement disorders involve these structures. They're the deep gray matters within the brain. So you have the cortex, and then you have the white matter tracts that kind of track into the brain, and then you have the deep gray matter tracts, which involve the nucleus caudate, the putamen, bulbus pallidus, interna, externa, subthalamic nucleus, substantia nigra, and also sometimes the thalamus is thrown in there as well. So these comprise a set of two main networks, actually, the indirect and direct pathway, which are very simplistically understood by us now, actually. But the idea is that the net effect of certain deficits in certain brain chemicals actually cause a net effect on the cortex, causing either a hypokinetic state or a hyperkinetic state, and that's the idea that's behind with hyperkinetic states, including Tourette syndrome. So, in order to diagnose Tourette syndrome, this is the DSM-4 criteria. Actually, you have to have both multiple motor tics and also vocal tics. It's kind of an arbitrary separation because vocal tics are actually motor tics of the vocal apparatus, so it's kind of neither here nor there. It's kind of, they're all tic disorders. And we just like eponyms, so Tourette's is actually, Tourette's is just one of them. But they have to occur many times per day for at least a year. The onset is before age 18. Some of the research criteria actually, it's below age 21 and have some other more specific criteria, but not due to medications or other neurological or medical conditions. So the management generally follows, first of all, recognition of the phenomenology of tics and the things that separate them from other quick movements, such as the urge to do them. But a huge part of it is actually education about what tics are, and what the understanding of the whole arena that the child encompasses, because oftentimes this occurs in childhood. So teachers, parents, their peers, if just a better understanding was made in these arenas, then it would actually not be as big of a deal and not as ostracizing to the patients who have it. So that can be a huge thing even before we get farther than that. And as I said before, behavioral treatment can sometimes trump pharmacological treatment at times, but there is pharmacological treatment for the more serious ones, and more recently there actually is surgical treatment for it too. Still relatively experimental and investigational, but it's actually happening, and there are trials that are going on out there. So the behavioral treatments, which are actually up and coming and becoming possibly first-line treatments for these, are habit reversal therapy. Sometimes the tics can be somewhat, there's a line between just habits, routines, and actual tics. And sometimes desensitization types of things, such as doing a performance and actually not feeling like you have to do them anymore, can actually be part of the management and sort of your own therapy for it as well. And supportive psychotherapy. While it was felt that it was perhaps more of a psychological condition back in the day, and now more of a neurobiological basis, to completely ignore the psychopathology of it, though, I think probably would not behoove the disease as far as the management, because it is a neurobehavioral condition, a neuropsychological condition, so to take those worlds together and treat holistically like that would be the preferable method. But there are medications that can be used for the more serious conditions. Sutie was put on haloperidol. These haloperidol and pimozide are actually two of the FDA-approved treatments for it. They block dopamine, and dopamine is very involved in the basal ganglia system, and sometimes an excess of that can cause hyperkinetic movements. And so, simplistically, blocking dopamine does help with that, but not always. There can be non-neuroleptics or non-antipsychotic medications that can be used, which sometimes we actually go towards, especially in kids, because yes, those antipsychotics are very powerful, and sometimes they can have side effects that you would not want to deal with later on. Interestingly, botulinum toxin injections can be used for treatment of tics, and actually has relatively few side effects. And there are some case reports that actually say that some can actually decrease some of the urges of doing them too. I typically use them on occasion in some of my patients if there's a particular movement that I can target on a particular muscle, because you can't really Botox everything. And then there's actually deep brain stimulation as well, which is an up-and-coming treatment. It is FDA approved in certain movement conditions such as Parkinson's disease, essential tremor, and generalized dystonia in children. But still quite experimental in Tourette's, although there have been a handful of patients that have had reportedly remarkable improvement, especially if they're of the malignant type that seem refractory to medications. And of course, I can't forget about concomitant treatment of the behavioral conditions as well. So the surgical treatment involves a two-part surgery for that. The first part is actually inserting the electrodes actually into the brain. There are several different targets for certain movement disorders. There are 3 or 4 experimental targets for Tourette's so far. But that's the first part of the surgery. The second part of the surgery is actually connecting it to the battery packs, which are in the chest. So that's the second part of the surgery in there. And then once they heal from that, they can actually get programmed by a neurologist trained in movement disorders for picking particular contacts to see if they actually help, which ones cause side effects, which ones are most beneficial. And once you find a good setting, then you can kind of go with those settings and hopefully it can provide some benefit for the patient. So that's it.